I intentionally left uncorrected the title of this talk that's in the program, which is not the title that I've given here. And the reason for that is that the issues related to cure are far greater than the virus and viral dynamics. And that's really what I want to try to talk about in an objective fashion, and a translational fashion where that's appropriate. So I want to actually start with defining what the problem that we're trying to solve here with HIV cure. And by that, I think we all understand that this is a sustained remission or functional cure, not a sterilizing cure or elimination. And there are several reasons that people will put forward in terms of the problem that we solve. This first one here, lifelong antiretroviral therapy is a challenge. There are resistance issues, there are adherence issues, quality of life issues, and adverse events. And this is what I call the patient-centered reason for HIV cure. The second is that expanding antiretroviral therapy and the needed infrastructure to provide care and treatment is not remotely sustainable in this era of flat funding. And so I would call this the public health and the economic-centered imperative. And the two graphics at the bottom on the left are the number of infected in orange and treated patients in blue. And on the right-hand side are the global allocations for HIV, which run on the order from an earlier slide of about $20 billion per year. And you can see that they've been largely flat since 2009, and in fact have gone down, even accounting for inflationary changes over the last 2 years. And further, that they fall well short of the anticipated resource allocations that will be needed to achieve anything remotely resembling a 90-90-90 or an AIDS-free generation. The third reason that I came up with is related to the flat global HIV incidence rates, which you can see on the left-hand panel. And for the last 3 to 4 years, global incidence has been about the same at about 2 million infections per year. So we're actually not making progress. We're just stalled or stagnated. And when you consider the population bulge that is anticipated to occur, and you can see that in the right-hand column, we are going to have in Africa the largest at-risk population for HIV since the epidemic began. So we clearly need some transformative approaches because we're not doing very well in terms of HIV. For those who are infected, we have a lot of efforts in long-acting therapy, in treatment and care, innovations, and deriving economies from better scaled treatment. And it's in that context of those who are currently infected that this functional cure idea arises. Could it be one of those transformative changes? Clearly, and I need to say no more than the preventive vaccine as a transformative issue in the AIDS epidemic. So what does cure have to do, and what can it not do? Well, it's got to overcome daunting biology, and I'm going to spend a little bit of time on that. We have to have a validated biomarker that will tell us when patients are likely going to rebound following treatment discontinuation. And that biomarker is most likely going to be a measurement of the HIV reservoir. We have to have an achievable target product profile, much along the lines of what Rakup just spoke of. We have to demonstrate cost effectiveness because we're doing pretty well treating those that can afford or access therapy. So we're going to have to really demonstrate we can do better than that, and we have to have engagement by industry or this will not happen. Well, what will end cure? And the absence of a biomarker that is predictive of who will rebound in what period of time following antiretroviral therapy is essential for the engagement of industry. In fact, drugs aren't developed today without a biomarker. You need a biomarker in phase 1 and certainly in phase 2 studies. It is too expensive and too risky to take a product into phase 3 without having first assessed the likelihoods of response. What else kills cure? Transmission, once antiretroviral therapy has been discontinued. The emergence of drug resistance when you take somebody off of antiretroviral therapy. The induction of oncogenes, and we'll talk for a little bit about that later on, and unacceptable adverse events. And actually, a survey has been done of completely controlled HIV-infected individuals to determine what level of adverse events they are willing to put up with for a curative regimen and not. And this will no doubt change over time and change in different populations. But the two things that were not acceptable, hair loss and nausea. So, some disclosures. I work for a small biotech. There are 4 of us called Bryologics. It works with bryostatin. And I work in the 2 therapeutic areas of immuno-oncology and HIV related to HIV cure. What I call the ART counterfactual, meaning what antiretroviral therapy will do, is pretty compelling. That's separate from the fact that we can't give it to everybody because we don't have enough money, but it's pretty compelling for what it will do. I'm agnostic to the question of whether cure is going to work. I am not a cheerleader for this. There are some fundamental questions. The answers will tell us, to those questions will tell us whether cure is possible. And quite honestly, the cure field is in need of some good news. We've been working on this for about 6 years now, and we know a lot of what will not work, and we know very little of what will. And the AIDS exceptionalism era is past. There are many compelling public health needs, and the monies will not continue to flow in HIV in the way they have in eras past. Those are disclosures and a few editorial comments, I guess, but I wanted to put them under disclosure. So here are the topics that we're going to cover. And I'm going to try to cover a lot of intense work, obviously, at a high level to make it, to have it make sense. The components of cure have been really laid out nicely by the NIH in an article from a couple of years ago by Tae-Wook Chun and Tony Fauci. And it relied upon 3 elements: viral suppression via treatment, and then what's become known as kick and kill, or shock and kill, activating the latent reservoir, and then affecting immune killing and clearance through a variety of means. Early antiretroviral therapy is an essential part of this, but as I'm going to show you, is actually not alone enough to prevent the establishment of the reservoir. Latency reversal to activate resting cells and to reduce reseeding, and then a series of immune interventions. Do you get to go back? The back button doesn't work. Okay. There we go. Thank you. Some combination of all of these elements, including therapeutic vaccination, passive immunization, as Rick just talked about, immune modulators, along with a kick agent and early treatment. The theory here is that this will allow us to discontinue antiretroviral therapy for some period of time where the patient remains aviremic with stable CD4 cell count, does not transmit virus, does not have immune or clinical events. The FDA has weighed in on this in an early fashion, a hypothetical fashion, and said that they see HIV cure in the same way that they looked at, or in retrospect, look at early first-gen hepatitis C agents. They weren't effective for everybody. Their duration was short. and the FDA has said a time off of antiretroviral therapy on the order of about 12 months. So some of our early work, and this is a slide from one of the VRC 01 studies, and I show it not to have you look at the comparison between the placebo patients in red and the treatment patients in blue, because you can see that there's substantial overlap here, but to really draw your attention to the red bracketed areas. And these are the patients and their time to viral rebound following treatment discontinuation. And as you can see here, there's a great deal of variability. In fact, about a log's worth of variability, patients rebounding within several days, up to about 4 to 6 weeks. And why this is going to be important is we have to understand what factors drive that, because can you imagine doing large clinical trials where the variability in the time to rebound would be a log? You can't do those trials. And this graphic, which is a built one, starts with the antiretroviral therapy on the left in red, following by treatment discontinuation. And this first green plot is the typical plot, just like the one from the VRC01 study. And here are the various examples of patients that we've had, sort of moving from left to right. The two so-called Boston patients who received bone marrow transplants, both of whom rebounded their virus. Actually, Mike Bush in San Francisco noted that these patients still maintained antibodies against HIV, which was probably the indication all along that they were seeing virus, their immune system was seeing virus, and they were going to rebound. And in fact, they did. And the well-known cases, the Mississippi baby, the Visconti cohort, which is this very important cohort that's defined post-treatment controllers, that I'll come back and talk about in a minute, the French teenager, and then, of course, the single example of the cured patient, Timothy Ray Brown, and you know his story. This is some work by Tim Henrich at UCSF, and he treated two individuals, one of whom is depicted on this plot, who received antiretroviral therapy within 10 and 12 days, one patient at 10, one at 12, of acquiring infection. Both were in PrEP programs, both could be followed very closely, and both received treatment for approximately 3 years and then underwent treatment interruption. And you can see the green plot, CD4, and at the bottom in black or blue, I can't quite tell, is the viral load. But these patients both rebounded in about the same period of 220 some odd days. This, along with some work from Thai investigators, has made it clear that while early treatment can be beneficial in reducing the size of the reservoir, it does not eliminate the formation of the reservoir in the first instance. And this is really too bad for us. In some macaque work, the reservoir seems to be fully formed within 3 days. There are two phenotypes of patients that are very informative as we think about cure. The first is the elite controller, and we've known about these individuals for some period of time. They have a relatively low frequency. They have specific HLA types. They have low levels of RNA at infection. At time of infection, they're highly immune activated, which isn't good for them. They have relatively few symptoms at diagnosis, and they don't need antiretroviral therapy. Their immune activation is a problem for them, but the virus and viremia itself is not. The other population that's very helpful for us to consider in the context of cure is this post-treatment control population. And this is more frequent, as you can see, 5 to 15%. They have no specific HLA protective type, and they're quite the opposite of the elite controllers in terms of their phenotype. They have high levels of viremia. They tend to have acute illness that often winds them up in the hospital with central nervous system and other manifestations. And upon early initiation of therapy, these individuals, in fact, if you stop their therapy, some portion of them, these post-treatment controllers, will maintain low viral levels in the absence of therapy. They're not viremic in the same way that elite controllers are. They tend to run viral loads in the low thousands. They can still transmit, but they don't progress their disease. So who are these folks, and what constitutes these two phenotypes? We don't yet know. So what have we learned from this first part? That the majority of cases of viral rebound will occur within days to weeks, and there's a considerable degree of variability that occurs. There are two unique groups of individuals that we would like to turn our, if you will, run-of-the-mill HIV-infected individual into either an elite controller or a post-treatment controller. Even the earliest antiretroviral therapy does not seem capable of preventing the formation of the HIV reservoir. And I'm going to skip the last one because the slide got put out of order. Some insights from the reservoir. This is an older depiction of where the reservoir is. And you can see from the top peripheral blood, lymph nodes, central nervous system, various tissues, and gut-associated lymphatic tissues. The point here is to speak about the various anatomic sites that are the reservoir, but also the heterogeneity of the cells within each of these compartments. And not all T cells are the same, certainly in terms of function, nor are they the same in terms of their permissive nature to HIV infection. There are, in addition, other cell types from the monocyte macrophage lineage that are likely very important. And so the take-home here is different anatomic sites, but within these sites, heterogeneity of cell types with differing permissivity to infection and immune control. One of the questions that was asked recently is the time of natural decay of the reservoir, as you know, is on the order of 73 years by the time all of the cells would be depleted. That was work that was done at the Clonal laboratory in the late 90s and the early 2000s. And that work was repeated more recently and was the subject of a 2015 publication that showed virtually the same reservoir decay. We seem to have lost a little of the detail from the Mac to PC conversion, but the time of reservoir decay is virtually unchanged by the era of antiretroviral therapy. So it's not got to do with the more potent, certainly not with the more tolerated, there it is, regimen. I'm going to walk through this slide a little bit because it talks about the components of the reservoir, but also some of the dynamics of the reservoir. So at the top are the latently infected resting CD4 cells. And upon stimulation with the mitogen, and so this is cell-based work, obviously, there are two populations of cells that emerge. On the left are the induced cells, and they replicate their virus. And on the right-hand side are cells that are not induced. And there are multiple subpopulations of these cells, and it's important to understand what is comprising these cells. Some of them are fully replication competent, but many, in fact most, contain deleted or hypermutated virus, or have stop codons, or have various deletions of one type or another. This is important because the relevant part of the reservoir does not include deleted or hypermutated or stop codon cells. It only consists of cells that are replication competent. Those are the only ones that we really care about. Defective virus we do not care about. A repeated stimulation of these cells will induce yet again another portion of cells to demonstrate viral transcription. This has led to an understanding that diagnostic tests for the viral reservoir have to include more than a single round of stimulation. I can tell you that most of them, until a new one, relatively new one, have not done that. And it's also guided some of our treatment thinking in terms of multiple doses of reservoir activating agents, or the kick agents. The reservoir measurement is really key here. And I want to actually start in this odd-looking diagram with the smallest portion in the red. This is the replication-competent virus. This is the stuff we're really interested in. And almost everything else there doesn't matter. And almost everything on that list has a test, a putative test for measurement of the reservoir, and most of what it is measuring doesn't matter. In another way, and this is the Clonal lab sphere, the magic sphere, and I'm a bit challenged on 3 dimensions. I actually do better on 2 dimensions, and so it took me a while to really get my head around this, and I'm not the only one. One of the Clonal's students similarly is impaired in terms of the 3 dimensions. But the blue portion of the sphere, it's going to turn into 2 dimensions in a minute, is what's detected by the PCR assays. And the PCR assays detect any kind of virus. Deleted, defective, hypermutated, doesn't matter, but it's not relevant. The intact virus is what's in that yellow cone or sphere, considerably smaller than the blue, and the QVOA, or the quantitative viral outgrowth assay, which has been the gold standard, and in many ways remains the gold standard, is just a sub-portion of that. I think we've come to understand that the QVOA underestimates the true size of the relevant reservoir. So here in now 2 dimensions, and looking on the left at the components of the virus, this is the same diagram proportionally, with way too much blue and a smaller amount of yellow and orange. And by eliminating the defective and hypermutated virus, you can actually shrink down to an even smaller level the amount of relevant replication-competent virus in the reservoir. And that's what we have to measure. Easy to say, not quite so easy to do. The Clonal laboratory, along with others, has developed a technique. It's down at the last bullet point there, the IPTA, or the intact proviral DNA, or inducible intact proviral DNA. And this is a test that's being taken to field now in a company that's been developed from the technology at the Clonal's laboratory, and will very likely be the gold standard. It requires some clinical confirmation at this point, but is a vast improvement at measuring the reservoir. Yep, can you go back one more? Thanks. So the establishment of latency and the maintenance of HIV persistence is an area that we've had some important insights into in the last period. And I want to talk about this. This is a very, to most of you, probably familiar graphic of the viral decay kinetics. And this was described many years ago by Alan Perelson and David Ho. And the first 3 phases were well described. What has been explicated in the more recent period is the phase 4, the persistence of the phase 3 and 4 being due to a phenomenon of clonal expansion. This has got to do with HIV integration. Now, I have to tell you that as a former clinician and one who likes pharmacology, integrase inhibitors, great thing. I never gave much thought, though, to what that meant, to where the virus actually integrates, and whether or not it was a random and stochastic issue, or whether there were preferred sites for viral integration into host DNA. Turns out there is. And this is determined by this pre-integration complex, which can vary in a variety of fashions, and the variability there has to do with where it enters the nucleus. And where it enters the nucleus gives it particular proximity to different portions of the host genome. There seems to be a bias or a preference that HIV has for integration into the host genomes at sites that are close to genes that regulate cell growth, including oncogenes. And in 2014, there were 2 science publications, one from the University of Washington and the other from the NCI group, that came up with nearly identical findings that there was a bias of integration towards sites where cell growth is controlled, and that there was integration in or very proximate to 2 of the well-known oncogenes, BOC2 and MKL2. So this is something for us to keep in mind. Clonal expansion during suppressive ART. So the first message here is that clonal expansion is not prevented by suppressive ART. It occurs. And clones expand. So on the left there are a variety of clones, viral variants and the viral swarm that's been spoken of. But not all of those particular viruses in latently infected cells will expand. There is a biologic advantage to the ones that do. And these expanded clones can carry replication-competent virus. And again, antiretroviral therapy does not prevent clonal expansion. These persistent clones may be activated by antigen, by immune function, because of inherent nature of these cells, and are responsible for the residual viremia that we see in individuals on fully suppressive antiretroviral therapy. So clonal expansion, to summarize, a lot of work seems to be driven, is an inherent part of human biology and pathobiology of HIV. It's driven by homeostatic proliferation, interaction with antigen exposure, and again, these integration site dependent areas that favor proliferation. So you've got these 4 components of latency, persistence, inflammation, and homeostatic expansion that are going on. And latency and persistence are driven by turning off of viral transcription and transcriptional factors through TAT and the resulting epigenetic silencing. Persistence is more downregulation of transcriptional factors and enhanced epigenetic silencing. And the cells, the resting latent cells, are invisible to the immune system. They're not surveilled, which is why they're not cleared by a healthy immune system. Inflammation through bacterial translocation and other forms has been described for a number of years. And it leads to cellular proliferation, cellular exhaustion, which drives homeostatic proliferation and reinforces latency and persistence. So what did we learn? That integration into the host genome is not a random process and favors sites of cell growth regulation. Low level on viremia may be due to a number of factors, constitutive factors, immune activation, privileged anatomic sites, and possibly inadequacies in antiretroviral pharmacology. Clonal expansion is what maintains viral persistence, and guess what? It's a problem. This is the last section on the lymph node follicle. This really starts with an understanding that humans and monkeys are different. We've learned a great deal from the simian models of SIV and HIV. But in one fundamental respect, humans are different from the NHPs, and that is, where is the reservoir? In monkeys, in the simian model, the reservoir is mostly in the gut. In humans, not so much. It's in the lymph nodes. This is a picture of Elizabeth Connick. You probably guessed that from the title, at the University of Arizona. And she has really led much of the efforts and our current understanding in the movement away from the actions in the gut to the actions in the secondary lymphoid organs. So I had to go back to medical school notes. Actually, I don't have any medical school notes anymore, so I went to Google instead and said, what's the difference between primary and secondary lymphatic organs? And it's really pretty simple. There are only two primary organs, the thymus and the bone marrow, and everything else is secondary. So here's a picture of a lymph node, and I said this is a quantitative pharmacologist's delight, and I'll tell you why. Because you've got blood, yep, and you've got lymphatic fluid, okay, and you've got anatomic compartments, and you've got different cells that are more or less permissive to infection, and you've got Rickup's CTLs that are impaired in their ability to get into the truly relevant portion of the lymph node. You've got a lot of factors you could play with here and come up with a really dandy model if you were mathematically inclined, but it's a nightmare for the cure world. So this is my rendition of the secondary lymphoid organ, the extrafollicular space in blue, the B-cell follicle in the dark orange, and the germinal center at the center. And there are a variety of cell types, both CD4 and CD8 cell types, different cellular phenotypes that are involved here. The secondary lymphatic organs contain the largest proportion of HIV RNA positive cells, and it's the predominant source in humans for viral replication during antiretroviral therapy. The B-cell follicle is a relatively privileged site from CTL control. The CD8 cells lack the homing receptor CXCR5 and therefore don't have access to where most of the infected CD4 cells reside. Furthermore, because it's a lymph node, dendritic cells are continually transiting virus from this low-level viral replication back to the lymph nodes. And the cells that reside within the germinal centers, the follicular CD4 cells, are the most permissive cells to HIV infection of all of the cells. This is like the perfect bad storm here. So anatomic, viral, immunologic factors enable new cellular infection in this very unique microenvironment, which really favors replication and persistence. There is a relative shielding of CTL responses within these lymphoid organs. And if this concept of pharmacologic insufficiency in HIV is real, we really have to understand this, because this is the primary battlefield here. And if antiretrovirals are not sufficiently entering this compartment to suppress viral replication, we'd best know that. And like the other problem, this too is a major problem. So where does this leave us? This is back to the Chun and Fauci diagram of what cure should look like, and going across the colored rectangles. Even the earliest antiretroviral therapy so far has not eliminated the formation of the reservoir. The latency reversal agents that we've been working with, primarily the histone deacetylase inhibitors, are very weak. They lack potency. They can induce some degree of viral transcription, but they do not reduce the size of the reservoir. And as such, they are insufficient as kick agents. PKC modulators and other agents are being looked at in early stage, though there are concerns about all of these agents. The therapeutic vaccinations, it sounds wonderful to enhance CD4 and CD8 HIV-specific responses, and likely it's going to be required to effect a cure, but none of the therapeutic vaccines that we've worked with yet have been able to accomplish this. Passive immunization in the broadly neutralizing antibodies, Rick has spoken to. There are issues of breadth and potency, the baseline sensitivity, as he mentioned, pharmacologic and cost issues. And the immune modulators are perhaps the best hope, working with the innate immune system to overcome the secondary lymph node problem. So just two last slides on final thoughts. The biology of latency and persistence and the heterogeneity of the reservoir is much more complex than anybody anticipated when we started this. Identification of the secondary lymphoid organs, certainly in humans, is the major source of reservoir, the major source of viral replication under ART. If we don't have a validated biomarker of the reservoir size to predict when people who undergo analytic treatment interruption will rebound, we will not be able to progress cure. Industry will not be involved, and without industry, we will not develop a curative regimen. The kick and kill paradigm is sound, but it's sort of like a blunt instrument. There's far more nuance than just kick and kill. And we must understand that the problem that we're solving for, back to the first section, and we're not winning this war against HIV. We're barely holding our own at the moment. So to succeed, cure must demonstrate sustained remission off ART, that it's possible, that it's cost-effective, that it's advantageous, that there's a market for this, and it's desired by the end user. And considering cure as a public health imperative, if we're going to fail, let's do it soon. Failing fast is the second lesson in industry. Succeeding, of course, is what everyone wants to do. But if you're not going to do that, fail fast so that you can put your resources elsewhere. And with that, thank you. And Terry, thank you for letting me run over a bit on time as well.